Okay, I'd like to wish everyone a good afternoon here on the East Coast. Good morning to everyone moving towards the West. My name is Brian Carey. I'm the VP of Marketing here at Unbound Medicine. I'd like to thank everyone for joining us today as we discuss a very important topic, the Measles Outbreak 2019. This presentation should last about 20 minutes, and there may be some time for some questions at the end. So if you have any questions, feel free to type it into the questions tab on your control panel or in chat, and then we'll be sure to get to your questions at the end. The webinar will be recorded and it will be shared with everyone via email and within your app, within the message center that you've probably recently seen very recently. We're also going to post it on the Unbound Medicine YouTube channel, so it can be viewed there at any time. So let me take this time to introduce our presenter, Dr. Paul Auwaerter. Dr. Auwaerter is the Sherilyn and Ken Fisher Professor of Medicine at the Johns Hopkins University School of Medicine, serving as the Clinical Director for the Division of Infectious Diseases and Director of the Center for Environmental Infectious Diseases. He serves as the Executive Director of the Johns Hopkins Point of Care Information Technology Center, the Pocket Center, producing the Johns Hopkins ABX, JHU HIV, Osler, Psychiatry, and Diabetes Guides. In 2019, Dr. Auwaerter served as the president of the IDSA, the Infectious Disease Society of America, the largest professional society worldwide related to infectious diseases. At this time, I'll turn it over to you, Dr. Auwaerter.
Brian, thank you very much for that introduction, and thank you for all taking time from your busy day for what I think is unfortunately a very important topic in many spheres of medicine and public health right now. By way of just some additional background, when I first started my career in infectious diseases, I was an immunologist and virologist, and what I studied was measles virus. And at that time, the focus was trying to develop new vaccines that could be used in younger children in countries with low resource settings where measles caused many cases in sub-Saharan Africa, for example, and it often was associated with infant mortality because of malnutrition and pneumonia. Over the years and decades since that time, measles really was something we rarely thought about here in the United States, but in the past decade or so has become much more prominent. And this is something that I think we'll focus on today and review some of the facts and myths, some of the frequent questions that I've been asked both by colleagues and patients, and maybe can help with your own personal questions or clinical questions that come up in practice. So we'll also talk about some of the underlying factors about how we've actually gotten to where measles is now part of our daily news headlines, as well as some guidance on prevention and so on. Now, some facts which I think, since no one really sees measles very frequently, unless if you're overseas and working abroad, this is a classic viral exanthem of childhood that generally begins a week to two after exposure. And when people first start getting ill, and the classic is so-called cough and coryza, that when those symptoms begin, people become contagious, and that's before the classic rash appears. So this is often where people might think they have a routine upper respiratory tract infection, but are probably transmitting the virus. And this is probably the most risky time, at least if you're not immunized or populations aren't well immunized. Who really gets the worst cases of measles are clearly infants and certainly children under 5. Also, adults who get measles fare pretty poorly, both from pneumonia and potential neurologic complications. As I've already mentioned, measles is one of the most highly infectious viruses, so the attack rates are definitely north of 90%. So if you're not with pre-existing immunity, if you're within a room and within 6 feet of someone with measles, chances are you will acquire the disease. As I've mentioned, the pneumonia and encephalitic issues are really what are most concerning. Although measles virus itself is certainly a disease that lays people low, it's really the complications, and certainly for pregnant women has been associated, unfortunately, with miscarriages and early delivery. Many of you may already be familiar with the myths. Probably the one that has at least been most highlighted is a now well disputed Lancet article that had in a small group of children associated the MMR vaccine, which offers protection against measles, mumps, and rubella associated with autism. A huge number of epidemiologic studies have not confirmed this link, both in North America, Europe, and other countries. But this remains despite the retraction of the paper and considerable investigations, continues to be, I think, the nidus that sort of sparked concerns, what many people have called vaccine hesitancy in terms of immunizing children, mainly in higher resource countries. It's also clear that we do have an existing measles outbreak in the United States. It is not another illness, and this has certainly been confirmed. And this is something that is spread human to human. This is not because of poor sanitation or communities where people are not following sort of standards. So this is something that can afflict people in rural environments, suburbs, and cities. So it is not just in isolated communities. The MMR vaccine has been documented to be very safe. There's a huge track record with this. So as long as you're not administering it to a person at risk, for example, it is a live attenuated vaccine, so you should not give it to anyone with a known immunodeficiency. But otherwise, the vaccine is very safe, and the side effects are really minimal. One of my kids actually had a very mild rash following the immunization that looked like a very mild case of one of the viruses. But that's about as bad as it usually gets in an immune person. And this really does provide durable immunity over the long term. So what's happening now, as many of you have read on the front pages of newspapers or in internet stories or television reporting, there is definitely measles outbreaks, both in Washington State and also in communities in New York, including Rockland County and Brooklyn, as well as other communities. And here in Maryland, we've had 4 cases. What's happened is that people tend to have acquired measles abroad. They're still infectious or ill. When they return, they come to a community where people have not had high levels of immunity. Some of you may be very familiar with the concept of so-called herd immunity. This has been very well studied, both mathematical modeling and otherwise, so that if community rates of immunization are north of 90 to 92%, you cannot get repeated infections such that you have spread into an epidemic. However, when those rates drop below 90% in some of these communities, such as in Washington State and in New York, are at 70% levels, this is where you have enough people who are without pre-existing immunity that the viral illness can continue because it is something that is only known among humans. It can only be spread that way and acquired, so you need susceptible human hosts to spread. And the countries where this has been most common has been in the former Soviet Union republics, particularly the Ukraine, also Israel, and the Philippines. This timeline, I think, is interesting. I just point out a few things that are sort of pertinent. The first is measles immunizations were first tested in the late 1950s. So anyone born 1957 and before has, because it's such a highly contagious illness, is assumed to have had native measles and therefore really have lifelong immunity. I have patients who are in their 70s, 80s, and even 90s who have called and asked in the past few weeks, should you get a measles booster? And that answer is very easy, and that's no. However, after 1958, some of the first generation measles vaccines did not provide good immunity, and in fact, sometimes were actually vaccines that had unintended effects. The so-called killed measles vaccine resulted into cases which we no longer see of so-called atypical measles when they were actually exposed to measles virus. So people between, I would say, 1958 and 1969 to 1970 may have had these older vaccines before the effective MMR combination was debuted in 1971 or so. So for people born in the late 50s and 60s, potentially may not have durable immunity, and therefore if measles virus is circulating in the community, that is something that you as clinicians should be aware. Measles was eradicated in the year 2000, considered eradicated from both the northern and southern Americas, so in our Western hemisphere. And the only cases subsequently were imported. However, there have been a number of outbreaks that have occurred, including the Disneyland outbreaks in 2014 and 2015, that first highlighted that if you have someone with measles in a busy population, there are enough under-immunized or non-immunized people that there could be an outbreak. And of course, here we are today with latest statistics that there have been 764 cases updated from this 550, which were just reported, that are known and confirmed. And probably that means there are others that just have occurred but aren't yet been logged or cataloged. So the reasons for the outbreak, as I mentioned, are generally someone with the ability to acquire measles travels abroad and is exposed, and then brings it back to communities in the United States that have low immunization rates or populations that are susceptible. And you can see the Disneyland outbreak here in 2014 through early 2015, and then now this year we now have the largest outbreak since 2000, when measles was considered eradicated, meaning we did not have cases of human-to-human transmission occurring widespread in the United States. So, as a long-time managing editor, now editor-in-chief of the Johns Hopkins Antibiotic Guide, which John Bartlett, our former division chief, had started now 20 years ago. Our guide's been around for 20 years. Initially, this was founded, and really we had a lot of drive to help people who could no longer carry heavy books in their white pockets, so things were very concise. And one of our first things was to try to have a lot of bioterrorism information on it, 9/11, because people really were not familiar with things such as anthrax. And so here again, even though this is clearly not bioterrorism, most people have not seen measles, have not talked about measles, and so on. So these guides, at least we structure them so people can find quick information to try to understand, should you consider the diagnosis, and how would you secure the diagnosis, what kind of things should you do. So for example, under diagnosis, we'll have some pictures of the characteristic rash, some of the classic symptoms, and then also how you might secure diagnoses, which are going to be mainly by serology. You can culture as well as provide PCR on respiratory samples, but you would want to do those in coordination with your laboratory and local public health department, and any suspected measles should be certainly reported to your local health department as soon as possible. And we also list the secondary complications. So people after measles are very prone to bacterial infections. That includes otitis media, pneumonias we've talked about, and diarrhea. Much more prone also to serious illness if they are malnourished. Less of an issue here in North America, of course, but overseas this is certainly the case. We offer treatment suggestions for children, adults, and then also highlight some of the unusual neurologic complications following encephalitis, including those that occur early with the disease, and then also the devastating problem of subacute sclerosing panencephalitis that might occur years after acquisition. In terms of prevention, I think anyone that sees children is very familiar with the 2-dose MMR administration, ages 12 months, 12 to 15 months, and then again in early childhood before school starts. And then also offer recommendations for adults, for example, who might be under immunized, geriatric patients, as well as those who you should not immunize. And then also recommendations for travelers, for example. And we've been doing this for years, where if someone is going to the Philippines or potentially traveling to communities in Israel or others where there might be circulating measles virus, or in the Ukraine or other aspects of Russian republics, that they may wish to have a discussion about risks for measles and whether they should be re-immunized. We also offer, and again, we don't have time in this circumstance to go through detailed issues regarding the immunization or when to use immunoglobulin, but we do have those recommendations in hand. And we also like to also give prompts to when, as reminders, you should call your local public health authority as soon as possible with a suspected case, such as measles or any of the other reportable diseases. For many people, the Centers for Disease Control offers very important and high-level information. What we try to do is distill it to the amounts that someone who's a busy clinician can look up in under a minute and review things and then get back to patient care, whether double checking whether they should or shouldn't consider, and so on and so forth. And we do keep these updated, and for example, with measles virus, we updated that module recently. As I mentioned, there are other resources, certainly the Centers for Disease Control, also the Infectious Diseases Society of America. I'll also mention that the Pediatric Infectious Disease Society of America and also public health authorities are great resources, so local, state, and local health departments as well, that have issued warnings. Here in Maryland, we've been getting updates about every week from our state health department. We've had 4 cases in Maryland, but it helps give some context and reassurance what might be going on in your own communities. As we get to a close, and if there are any questions, one of the most frequent ones I've fielded recently is who should get a booster. And as I mentioned, it's what I would call optional for adults from 1958 to 1969 if they don't have a contraindication, because they may have gotten one of these less effective vaccines. Now, for example, if you're in the midst of Rockland County, I would say options in Rockland County, New York, where there's an ongoing measles epidemic outbreak. Your options really are to check a measles antibody titer, or you could just give someone a dose of the MMR vaccine. Either, I think, is acceptable, although if there's an ongoing epidemic, it might be just as easy to administer the MMR. Here in Maryland, where there really doesn't seem to be ongoing disease, you might check a measles antibody titer, that's the IgG titer, not the IgM, and see if you have demonstrable antibodies, and then if you don't, certainly offer an MMR vaccine. So this is amongst one of the most common questions I get asked, and as I've already mentioned, if you were born before 1957, that's considered not to have a concern because of durable immunity from native infection. So in summary, measles virus certainly is highly contagious. I can't overemphasize that. Much more so than other respiratory viruses. Outbreaks will occur if your local populations might have immunization rates below 90%. So cannot emphasize that immunization is a way to make this all go away. Certainly individuals who have concerns and vaccine hesitancy contribute, but we also like to emphasize that for the common good and for public health, that you really, by immunizing, you not only protect yourself, but you protect others in your community. So this is why I call it, it's a selfless act to do this and to emphasize. Measles is most dangerous for young infants and younger children as well as adults. And then if you have cough, coryza, and a rash, and Koplik spots, these little blue whitish dots just near your incisors on the gums, this might represent measles, and the vaccine is safe to administer or re-administer. Immunization rates are generally north of 90%, with one vaccine dose around the 93% range and up to the upper 90s with 2 doses. So it's safe and effective as long as someone doesn't have a contraindication. So I'll turn this back to Brian. I don't know if we have any questions that I can try to help address, but I do want to thank you for listening to this. There's more detailed information if you do have the Johns Hopkins Antibiotic Guide, as well as some of the other resources which we've outlined.
Thank you so much, Dr. Auwaerter. We did have a couple of questions. One was, do you recommend giving the MMR vaccine to pregnant women?
Right. So you want to do the MMR before pregnancy. German measles is one of the things associated with congenital diseases. So if you have someone who is suspected to be pregnant and exposed, there's a certain approach you would take. But yes, no, you would check those titers beforehand. And the rubella is one of those that are on a typical prenatal panel.
Great. So another question was, would you advise to take vitamin A for prevention?
Yeah, there have been studies regarding improved outcomes in children who are mainly malnourished in Africa who take vitamin A, and it seems to reduce the complications of measles. I am not aware of any data that vitamin A offers protection from the actual infection. It's rather it helps if someone is malnourished or undernourished, and typically this is only employed in lower resource settings.
Great. And I think we have time for one more, and then more of a grouping, there's a bunch of questions on similar topics that I'll help address, but one that's more clinical would be any special recommendations for healthcare providers who have already received 2 doses of MMR?
It's a great question. Healthcare workers, of course, could be exposed. The assumption is that most people are going to be seropositive or have durable protection. However, most hospital systems certainly, often upon a condition of employment, check these titers. And if you're not seropositive, you'll be reimmunized. Now, you're usually not followed again. Again, the concept is that for most people, if the community is north of 90 to 92%, you're not going to have circulating measles virus there. So typically, if you've had 2 documented doses of MMR, that's sufficient. So that's one of the ways or at least we trust, that you don't need to do anything else. If you're someone that's between 1958 and 1969 to 70, you could re-administer an MMR or check a titer. Those are options if you're a healthcare worker and have a concern that you don't have the documentation or recollection of having proper vaccines. But I would say anyone after 71, unless your personal circumstances were that you didn't get routine pediatric care, should have received proper dosings, although initially it was only 1 dose, but subsequently became a 2-dose MMR.
Got it. Thank you so much. A couple of the questions that came across, one was, would people be able to access the PowerPoint slides and this presentation? As I mentioned in the opening, the presentation and webinar has been recorded, and everyone that attended this, as well as anyone that registered, or anyone that wants to take a look at it, it will be posted on YouTube, and we will send everyone access to the video. It will also be accessible through your message center on your Johns Hopkins app. We did have some questions about the Johns Hopkins guides. So if you are interested in an individual copy of the Johns Hopkins guides, it's available for a free 30-day trial that can be downloaded from the App Store. Or can be previewed in the Google Play Store. So you go to your app stores and you can go there and take a look at it. There was also some questions about having it available for your institution. It is available institution-wide. So feel free to reach out to sales@unboundmedicine.com, and we'll give you some information on making it available to everyone at your institution. If there were some more questions that were popping up as we were going, so what we'll do is we will send these to Dr. Auwaerter, and if he has time, we'll be able to get them answered, and we'll send them out to everyone, and so everyone can see the questions that were asked and the expert advice that was added to it. So at this time, I'd like to thank Dr. Auwaerter for his time and his expertise today, and for everyone that decided to come to Unbound Medicine and listen to the webinar. Everyone has a wonderful day, and thank you very much.
Thank you for listening.